It is May 18th, and the state of South Carolina just opened back up again. So I got to wake up nice and early at 4 o'clock this morning and roll out to the gym and get a real exercise in for the first time in a couple of months. And as I was driving back at 6:30 in the morning, because I had already finished my lift by then, I drove by this barber shop, right? And outside of this barber shop was this old dude, like 60 or 70, gray white hair, and he was just standing there like with his arms crossed in front of his truck, and he wasn't moving. And I was like, oh my word, this dude is waiting in line to get a haircut before the barber shop is even open. And so that's the state of the world right now, May 18th, 2020. And I bring this story up because the message was really on my heart to impart to you that some things in the world are just not that important, you know. And I saw this dude waiting for the barber shop to open, and I felt bad for him because I know what that feels like to be so attached to something that you think is really important, but you're the only one who thinks it's as big as a deal as you think it is. And nobody else really cares that much about it. And this dude thinks that getting a haircut, I mean, he had hair as short as I do, you know, but like he was obviously like, oh, my hair is too long. So to him, his hair was a big deal. But like to everyone else in the world, he could have been bald and he'd still be the same person. So that was a message that was on my mind and my heart today, was just to say to you, don't get too caught up in the little things like hair, you know. And if you find yourself getting too caught up in something, too attached to something, take one big step back and think about it one more time. And if you're still attached to it, then maybe you ought to be, you know, but maybe you're attached to it and it's not a big deal at all. So cardiac tumors, I just first passed this lecture and I wanted to record this video while everything was still fresh on my mind. It's actually simple. Um, these tumors all cause they can cause a myriad of symptoms depending on where they are in the heart. And for most of them, there's no rhyme or reason to where they are in the heart. So it's useless to try to learn the symptoms because you're not going to be able to predict, you know, you're going to be reacting to where these tumors are whenever you find them on an echo or an MRI or an X-ray or within a question stent. So there's no symptoms really that you have to learn for this. If you've been doing your other SDLs diligently, you know what's going to happen if you have a mass somewhere in a conduction pathway. If you know the anatomy of the heart, then you know that atrial masses are going to be between the SA and AV node, and then septal masses in the ventricles are going to be downstream from the AV node. And then if you've been doing your EKG, you know that the pacemaker rhythm is going to reset to certain rates depending on where a conduction block is. And then obviously left chamber, right chamber, left septum, right septum. Masses in either can cause a left or right bundle branch block respectively, and you should know how those present by now. And these things can embolize, they can cause strokes, they can occlude a valve, specifically the mitral or tricuspid most common, but sometimes the aortic. And so you can get a stenosis, a pseudostenosis of a valve whenever there's a mass effect, mass lesion growing into the lumen of the valve. You could also get a regurgitation if the valve itself was compromised. And so there's really no symptoms to take away from this text in particular. They're symptoms that you ought to be able to coordinate pathologies around based off of your current knowledge. So tumors of the heart are very rare. Most often they're metastases. When they're primary, they're typically going to be atrial myxomas, and then there are going to be a couple of specific tumors in children. So that's where we're going. Atrial myxoma is half of all adult cardiac tumors. It's a benign tumor. It grows out of the atrial septum, and it's got a myxoid histology to it, meaning that it's got various cell types interspersed in a jelly-like substance. There's a lot of ground substance here and a lot of extracellular matrix. Most of these myxomas will occur in the left atrial cavity. So if they embolize, they're going out to the system, not to the lungs. Although if it is in the right atrium, you can get a pulmonary embolism if a part of the myxoma breaks off. Grossly, they're going to be attached to the side of the atrium, usually specifically attached to the medial atrium, to the interventricular septum. On histology, they're characterized by this loose myxoid stroma, and no other tumor is really going to appear with this combination of a round gross mass and then myxoid histology in the heart. So it's relatively easy on that front. It's got a tumor suppressor gene mutation, the protein kinase A regulatory unit. So it's a tumor suppressor gene, so you need to lose both of them really in order to get the cancer. So maybe you've inherited one dysfunctional copy, and then any mutation in the other copy is what will lead to the development of the cancer, as opposed to an oncogene, which is going to be a gain of function mutation, not a loss of function mutation. Big symptom for an atrial myxoma is the protrusion of the tumor into the atrioventricular orifice, and this is going to mimic a mitral or a tricuspid stenosis. And so we know that with a mitral tricuspid stenosis, we're going to hear a pandiastolic murmur, the one that starts off tall, goes low, and then peaks up again at the end of diastole. So that's the murmur that we're going to hear. And then where it is on the chest is going to lead you to mitral or tricuspid valve. And then anytime there's a stenosis, well, then if it's a tricuspid stenosis, the right ventricle isn't getting enough volume, and then blood's going to back up into the venous system. And so you're going to see ascites, you're going to see distended jugular veins, you might see pitting edema. And if it's on the left side of the heart, if that mitral valve has a flow occlusion, well, then the left ventricle will be volume underloaded, and so you'll have a low cardiac output. But then that left atrium will be volume overloaded, so fluid will back up into the lungs, and then due to the high hydrostatic pressure, you get an edema, you're going to get a tachypnea, that J reflex will kick in, and that's the symptoms there. So refer to the heart failure SDL, really, if you're having problems tracking those. Again, they can embolize. Embolisms are fairly common. If they're on the left side, it's going to be systemic, right side pulmonary embolism. Very, very often, you don't make this diagnosis until autopsy because they're so benign in a great many of cases. And then if they do embolize, well, then the patient can die from that. And so rare is the case in which you're making this diagnosis on a live patient. Here we've got a CT that shows the attachment in the left atrium, and you know you're looking at the left atrium here because it's the posterior most chamber of the heart. And then this would be your aorta behind it. And then so it's going to be right atrium up here, right ventricle, left ventricle. And I thought this was cool. Constitutional generalized symptoms are likely due to the elaboration by the myxoma of interleukin-6, and interleukin-6 is a pro-inflammatory cytokine. So if it gets in the blood, then it's going to cause the acute phase response from the liver. It's specifically interleukin-6 is able to upregulate those acute phase proteins such as CRP. And then we treat that tumor by taking it straight out. It can show up again if we don't do a good enough job of cleaning the site. So a Kearny complex is closely related to the atrial myxoma. A Kearny complex is basically an atrial myxoma in the landscape of other benign tumors. So the patient has many tumors, one of which is going to be the atrial myxoma. That's the Kearny complex. And they can include schwannomas, which we've learned about, specifically the vestibular schwannoma, as we see in neurofibromatosis type 2, is going to interfere with the cranial nerve 8, your vestibulocochlear nerve, and it's going to cause maybe a unilateral or bilateral deafness. You can also get testicular tumors with the Kearny complex. You can get pituitary adenomas, leading to a whole host of symptoms mediated by hormonal release. And then you've got this characteristic dermatologic presentation of these lentigines. I love saying that word. Man, that word just flows off the tongue. Lentigines, you know. Well, it's a plural word and the singular word is lentigo, right? Which is also a very fun word to say, lentigo. So a lentigo, what is a lentigo? It's an age spot or a liver spot. If you've ever seen an old person, specifically an old person that likes to be out in the sun, likes to be outdoors, then they might have like these spotty brown discolorations on their face. And I don't know where you're from, but where I'm from, I've heard them referred to a couple times as liver spots, even though they have nothing to do with livers. But that's what they look like. They're macular, they're flat, and they're lentiginous. And then there are these epithelioid blue nevi, which it looks like, I mean, that's as buzzword as a buzzword can get, yo. So I'm not too worried about that. I'll Google images that, and then I'll forget about it ever. Spotty skin pigmentations, that's the lentigines. And if you biopsy a lentigo, then you're going to see hyperpigmentation of the basal layer with hyperplasia of melanocytes. And then if you biopsy an epithelioid blue nevi, in comparison, you're going to see melanocytes migrating up towards the skin. So normally the basal layer of the epidermis is going to be the deepest layer, the bottommost single layer of basal cuboidal type cells. And these basal cells are what divide. They're the only dividing cells, actively dividing cells in your epidermis. And when the basal cells divide, they crowd each other out alongside the floor of this membrane separating the epidermis from the dermis. And as they crowd each other out, then some of the basal cells start to detach. And as soon as they detach, they're no longer a basal cell. They're considered a squamous cell. And then that squamous cell is just pushed to the surface by the process of so much cell division and multiplication within this basal cell layer. And so whether a cell is attached to that basement membrane or not is the only difference between a basal and a squamous cell carcinoma. And that's also why basal cell carcinomas tend to be a lot worse and have a higher metastatic risk, is because the basal cell layer is actively dividing, but the squamous cells, which is going to be the 4 layers of the epidermis above that stratum germinativum, those do not actively divide, and so their risk of expanding and metastasizing is very, very low in comparison. So there's the histological difference between the two different skin lesions, if that happens to be a question. And the cardiac myxomas, we just reviewed the atrial myxoma specifically, but myxomas may be found in any of the chambers of the heart, and the same risks are at play here, specifically embolization, and then if they're in the atrium, blockage of one of the AV valves. Myxomas may develop on the skin, and that's typically how this is caught, is the patient realizes that they have some skin tags and the dermatologist biopsies and says, oh, hey, this is okay, this is a cancer. And so then they look elsewhere and they find other tumors, and that's that. So Kearny Complex, not because of anything. Kearny complexes and what we just talked about, atrial myxomas. Well, we know Kearny Complex encompasses atrial myxomas. Myxomas are part of the picture of Kearny Complex, and so the same gene mutation is at play. And it's this PRKAR1A TSG. It's a protein kinase A subunit, and it's going to be a loss of function. So protein kinase A is activated by cyclic AMP, and we know that levels of cyclic AMP in the cell are controlled by the activity of adenylate cyclase. And typically adenylate cyclase is turned on or off by G proteins, right? So a GS protein can turn on adenylate cyclase, and a GI protein can turn it off. And typically growth factors binding to a multimeric G protein are going to send a GS over to adenylate cyclase to make cyclic AMP, and then PKA is going to get turned on. So this regulatory subunit is going to be part of what helps turn PKA on and off. And so it might not make a lot of sense. You're saying, oh, well, if PKA is on, or if PKA is off because that's what would happen in a tumor suppressor gene, well, then why is there growth? Because I thought growth factor signaling was involved with PKA, but that remains unclear. I'm tempted to say a lot of things about glucagon right now because I have a feeling that I know why it's like that, but I'll save that for another time. So papillary fibroelastoma, this is also a benign tumor. This one, it has such a characteristic look, yo. You can spot this guy from a mile away. He's like that dude who's always wearing a jersey at the bar. Typically, old people get this tumor. It looks like a sea anemone. It looks like a sea thing, right? And it's got a stalk to it. It's got fronds. It's papillary, and it's a wavy tumor. And it's also benign, right? But this thing can also pose a risk of embolus if it happens to break off of that thin little fibrous stalk. Now, these things are avascular. That's kind of important for histology. And they've got a central core of myxoid tissue, but then they've got a surface endothelium to them as well. And papillary fibroelastomas are going to be due to gain of function mutations in the KRAS gene. And the RAS pathway is a growth factor signaling pathway, and it's going to push the cell farther and further towards the S phase of the cell cycle, right? Because you have to finish G1 before you can go into S. And so if you have an oncogenetic mutation, what that typically means is that it's some sort of mutation that lets you get through G1 more efficiently in a more timely manner. So that's how it contributes to cancer. Again, big risk here is embolus, but then depending on where it is, arrhythmias are possible. This thing could embolize into a coronary artery. That wouldn't be good because, I mean, look, it's right there on the outside of the atrial valve or aortic valve. So lipomas, we've seen lipomas before. They're comprised of mature fat cells, and they can happen in the heart. And if they happen in the heart, well, then they pose a big risk for growing into, encroaching into the myocardium and encroaching into the conduction pathways and crowding them out and causing your neurons within the heart to get stretched and injured. And this can lead to an arrhythmia. Then we have this similar concept of lipomatous hypertrophy of the atrial septum. And this is not a cancer. This is the one thing in this SDL that is not a cancer. It's a benign lesion, and it's caused by a whole lot of fat, white and brown, mixed in with some myocytes. Again, it's going to occur at the atrial septum. So conduction deficits are a big threat because the SA to AV node, to get to the AV node, that conduction bundle has to go through the atrial septum. Histologically, you see a bunch of mature adipocytes, some myocytes mixed in, so very similar to a lipoma, easy histology there. And then the arrhythmias are really, really emphasized in the two lipomatous pathologies in this text. I thought that was something I spotted. So then we get to a couple of pediatric tumors to wrap this up, and then metastasis. Cardiac rhabdomyoma is the most common pediatric heart tumor. It's strongly associated with tuberous sclerosis, which is going to be a sort of syndrome, right? That presents very similarly across people with some minor differences. TSC is inherited in an autosomal dominant manner. A rhabdomyoma, well, it's not a sarcoma, so it's not malignant, right? And rhabdo is meaning muscle. Grossly, this is going to be a firm, white, encapsulated, well-circumscribed nodule in the myocardium, and it can be so small as to be entirely within the thickness of the myocardial wall, or it can grow large and it can protrude out of the wall and grow into the ventricular lumen. Histologically, these cells have a very distinct appearance. Nothing else in this SDL looks remotely close to this. And the reason why they're all washed out is because these rhabdomyocytes, these myocytes, the cancerous cells, have a whole lot of glycogen within them. And we know that cancers like glycogen because of the Warburg effect, which says that cancer cells like to switch to anaerobic glycolysis. That also creates a more acidotic environment because, well, anaerobic glycolysis can only go to pyruvate, can only go to lactate. You know, if you're not going to throw that pyruvate into the Krebs cycle, well, then you got to get some NAD somehow. And so you do that with lactate. You run your pyruvate dehydrogenase, your lactate dehydrogenase, and that's going to pop off a proton. And we know that cancers also like acidic environments. Clinical features are extremely variable depending upon location, size, and number of tumors in the heart. So now we've got a section about tuberous sclerosis complex. This is highly testable. I expect a question from here, indubitably. You get hamartomas in multiple organs. The brain, the eyes can potentially be affected, and we've already learned about those two things. The skin as well, that would be an obvious place to pop a tumor on a test question patient. So it's similar to a few other neurocutaneous disorders that we learned about in block 3, and those are specifically neurofibromatosis 1 and 2. Sturge-Weber syndrome, we're looking at this block. Von Hippel-Lindau, we got a little bit of in block 1, but that's mostly associated with kidney disease, pheochromocytomas, and renal cell carcinomas. And so I don't think VHL would be on a test question, but we have been asked the whole, which other disease is most similar to this pathology? And so the answer to that amongst these 4 options, I believe, would be NF2, because that involves a tumor suppressor gene, Merlin specifically. And neurofibromatosis type 1 involves a oncogene. So TSC involves a tumor suppressor gene. Specifically, there's 2 actually, hamartin and tuberin, and they combine with each other to form a complex. And I believe that TSC1 can complex with itself if it needs to, and you'll have a reduced function, but it'll still be able to function. But TSC2 can't complex with itself. It needs TSC1, and so that's why a TSC2 mutation is worse. And this TSC protein complex turns off the rapamycin kinase cascade, and that's called the mTOR pathway. And mTOR is activated by a whole lot of things. mTOR is actually active whenever you get done with the workout and your cells really want some protein, and so you go take a protein shake. Well, that protein activates the mTOR pathway, and it gets your cells growing and dividing. And again, we said that anything that's going to push yourself through the cell cycle, that's the real crucible of cancer, is the cell cycle, right? And so that's the end of the day effect. Whenever you lose this complex, you're more prone to go from G1 to S. And because it happens when you lose the protein complex, it's a tumor suppressor gene and not an oncogene. And that's a very, very critical idea amongst any cancer SDL. So you see an increased risk for renal cell carcinoma. I think that's a fair game for what complication would this patient have? Again, 4 out of 5 TSC cases are due to the TSC2 gene, not the 1 gene. And TSC2 mutations tend to be very severe and present in early infancy. And then patients with the mild form, the TSC1 mutation, that might present in adulthood, and that's going to be the type of thing you would only catch because the patient's got a skin tag or something, right? So specifically talking about TSC2 mutations now in the severe form of tuberous sclerosis complex, you can get glial neuronal hamartomas. And this can lead to macrogyri, and this is going to be a type of, I want to say lissencephaly if my memory serves me right, but we've seen these sorts of migratory disorders, because your neurons, your little baby neurons, they got to start somewhere, right? And they start in this ball, right? And then they migrate outwards. And that's how you get your cortices, is the migration of neurons outwards. And so they've got a plan, right? And they've got a map. But if you mess up their map, well, then they're like Ron Burgundy. They only read the script. And so they're going to go to the wrong part of the brain. And so when your neurons, your baby neurons, don't follow the map right, you get big old gyri, or maybe you don't get any gyri at all. So it's a neuronal migration disorder during development. You see pyramidal cells on, here's the histology, pyramidal cells without the traditional 6 neuronal layers of the cortex. You can see 2 types of different hamartomas in the brain. You can see subependymal glial nodules or subependymal giant cell astrocytomas. And they're both going to occur in the walls of the lateral ventricle and in the foramina Monroe. And we know that can lead to a hydrocephalus. And I think that's a highly, highly testable concept here on this test, because we've already learned it. And here's the histology for both of those 2 tumors. It's underneath the pictures of the physical diagnosis. Talking about physical diagnosis of tuberous sclerosis complex, you either get these spots of hypopigmentation, or you get bumps all over the malar region of the face, right? Over the nose, going down to the corners of the lips. And then there are a couple of further manifestations. Again, you're at risk for malignant tumors elsewhere, renal cell carcinomas, glioblastomas, angiomyolipomas. So these 2 up here are benign. The subependymal glial nodules, subependymal giant cell astrocytomas, remember, those are both benign, and a glioblastoma is malignant. So pay attention in the question stem to see, are they asking you about a benign or a malignant tumor? Because that's how you take an easy question and make it hard. You put in one little detail and see how many people miss the detail. So they could say, what's the most common? And you're like, home run, and it's like swing and a miss. So read the whole question. Lymphangioliomyomatosis, really nice words in this SDL. That's a particular tumor that affects women, and it's in the lungs. So just because that's such an exception to anything else in this passage, highlight that. Cardiac fibroma, number 2 most common tumor of childhood, heart tumor of childhood. Got this super characteristic histology. Man, I am grateful, you know, because after we had brain tumors, I was just like, I don't want to touch cancer histology for a minute, you know. It's like I don't want to go into that, but this histology, oh, it's benevolent to us. It smiles upon us, right? So this is a fibroma, and it's like, oh yeah, I could have told you that was a fibroma without even reading this SDL, you know? It's like, give me multiple choice. Like, well, is that a fibroma or a myxoma? It's like, you know, it's like nobody has to think about that. This is easy. It's a lot of sheeted cells. They're very densely connected. They're plastered onto each other very tightly. So fibromas, what else do we have going on here? Well, we got this patch 1 mutation. Doesn't even say if it's a oncogene or a tumor suppressor gene, so it's like patch 1, right? You can get basal cell carcinomas, and that's typically how you diagnose the fact that the patient might have a cardiac fibroma, is if they have a lot of basal cell carcinomas. And again, those are the ones that are potentially malignant. Well, then you want to start looking elsewhere for other cancers you're not picking up, because this patient's probably syndromic if they're getting multiple basal cell carcinomas at a young age. Central calcification is frequent. It's the only tumor in this SDL that is specified for. So yeah, I think it's fair to assume that if you get an X-ray and it's got a big white dot in the middle and it's in the heart, and it's a kid, fibroma, you know, it's like, what else is it going to be? And histologically, with words, what the picture up there says is bland fibroblasts and collagen arranged in fascicles. So that could be another angle to question. Finally, we're talking about secondary cardiac tumors, those that start elsewhere and then migrate to the heart metastatically. The most common tumors. So the most common cardiac metastatic tumor is lung cancer. Number 2 most common is breast cancer. But the one with the highest rate of metastasizing to the heart is going to be the malignant melanoma. And we see a malignant melanoma all the way up at the start of this SDL. It's right here on the right. And this is another example of, again, sweet histology, because it's like you look at that and it's like multiple choice question. Well, if option D is melanoma, again, it's like, I mean, the thing's like squid ink, it's jet black. It's like, yeah, I think there's a lot of pigmentation in there. So it's like, you don't even have to know the lecture to be like, oh, metastatic melanoma, you know? So this whole SDL is really throwing us a good pitch to hit. This is an important sentence. Lymphatic spread gives rise to pericardial metastases, and hematogenous spread gives rise to myocardial metastases. Just because you could get symptoms and then they could correspond with pericarditis or myocarditis, right? And then you work backwards and get to how did the cancer get there? The clinical presentation, well, if you get pericarditis, then you're going to have a pericardial effusion, which that's in a different part of a different SDL. But whenever you perform the centesis and you draw some fluid out of there, well, it can be sort of a pink translucent, right? Which means it's some blood, but it's mostly this serous effusion. It's blood tinged with a little bit of blood in it. And that's typically due to capillary overdilation, creating a leak, an exudate, and then some red blood cells are following, because that's how leaky the endothelium is, right? And so the combination of an exudate plus red blood cells gives you this serosanguinous effusion. And we know that whenever a cancer roots into a tissue and plants itself there, it's going to release lots of vasodilatory cytokines to get itself some blood flow, to get itself some nutrients and growth factors and all that good stuff. And then hemorrhagic, that's nothing but blood at that point, and that's a problem, and that can often be due to a mass lesion growing through an endothelium and just causing blood to spill everywhere within a tissue. And so that's how you can get hemorrhagic pericardial effusion, that or trauma. So as a conclusion to this SDL, the most common heart tumor is metastasis, most commonly from the lung than the breast, but of highest proportion from melanomas. Kids got 2 types of heart tumors to worry about. Number 1, rhabdomyoma, which has a lot of muscle in its histology. It's a muscular, benign muscle tumor, and it's associated with that tuberous sclerosis complex. And then a fibroma, which looks like a UPS box on histology. It is so plain. And then adults, you got 2 big types of tumors here. Your atrial myxoma, which typically grows out of the wall of the interatrial septum. And then your papillary fibroelastoma, which has a stalk and an anemone on the end of it. And remember that there's this variant of the myxoma called, what is it called? Kearny Complex. So Kearny Complex is going to be myxoma plus other tumors. And then malignant tumors of the heart, didn't talk too much about those, but you can get an angiosarcoma, you can get a leiomyosarcoma. So that's it for this cardiac tumors SDL.